local factors like underlying pancreatitis or cancers. Cancer is a very important thing. There is an article in the recent NEGM which has shown that 7% of the patient who was presented with unusual thrombosis, they are known to present with cancer within a year or 6 months.
Next slide.
And yeah, complete blood count will give you a lot of clues, and myeloproliferative disease is the most important thing, which has been shown to cause, in various series it has been shown as high as 50% of the patients may have a underlying myeloproliferative disease, and this may be the first presentation. You may not, sometimes you may end up seeing a mild thrombocytosis which you might think is a reactive phenomenon. So you have to be aware, because in the presence of a thrombosis, the platelet count which was very high would have come to a borderline level, and maybe after 1 or 2 months you will see a platelet count of 1200, which is 12 lakhs or 14 lakhs down the lane. Another thing is PNH, which is rare, but you have to keep in mind, and easy because patient may have anemia with ongoing hemolysis, which you can hit up by raised LDH and RT count. Sickle cell presenting with the splanchnic thrombosis is rare. And in younger patients, the commonest is antiphospholipid syndrome, which you have to always look for in younger patients.
Sure, next slide.
And screening for congenital thrombophilia, you can, many patients, the congenital thrombophilia screening need not be done electively initially. It can be done later on also, because sometimes patient having congenital thrombophilia may not have thrombosis. A lot of patients may be this, so finding a congenital thrombophilia may not fix the cause.
Sure, next. I think CT abdomen was done, and it showed a non-visualized extrahepatic portal vein, thrombosed to superior mesenteric vein with portal cavernoma, portal hypertension with portal systemic collaterals. So obviously it is a chronic process. And enlarged spleen, hyperplastic left hepatic segments, and multiple small renal calculi. Next slide. So currently we entertain a diagnosis of extrahepatic portal venous obstruction with portal hypertension, superior mesenteric venous thrombosis. Anything else from the audience? Do you want to add on? Next slide. So I think they will take in sequence medical management and radiological intervention if there is a need, and subsequently by hematological management. From the audience, we will have some contribution on surgical management on this patient. Next.
Before this, I think we need to know the endoscopic report. The reason is he is a patient with portal hypertension, and the medical management will depend largely on what is available to us based on the upper GI endoscopy. Because taking the issue, just sorting out the what was the finding in this patient basically on this?
Upper GI endoscopy showed varices. He had esophageal varices at risk and gastric varices also.
And gastric varices.
Gastric varices type 1.
And what was the results on the thrombophilic factors?
No, we couldn't do at that point of time. Salem probably is inadequate, and we started treating him actually.
So based on the history, we presume that it is an acute thrombus, and since no acquired causes were known, probably it is one of the thrombophilic factors, which may be about 10 to 20%. So we'll have to take this as one of the rare possibilities. So in this particular patient, I think, as we go along, I thought the varices were the main thing that should have really contributed to the management of this patient, rather than managing the anticoagulation. So should we take up the discussion as it is, or?
We have it in the subsequent slides, ma'am. We have it in the subsequent slides.
No, because
currently, please.
If the patient has grade 3, grade 4 varices.
Now this patient, let us leave alone varices now. Let us have only this question now. There is a superior mesenteric venous thrombosis. How are you going to manage medically?
That is with anticoagulants.
Okay, we will go to the next slide. Yes. Next. Yeah, Dr. Sundar Kannan.
The general principles of DVT applies here also. You have to find out whether it's a provoked or unprovoked. Provoked in the sense whether there is a local cause, in which case you can have a short-term anticoagulation. And obviously this is an unusual site. And next slide.
Yeah, next slide.
Yeah, in any case of acute thrombosis, you have to look for most importantly the transient risk factors, if there are any. Other than the local factors, as I said, we have to look for recent onset of myeloproliferative disease or antiphospholipid syndrome. And the other thing is severity of thrombosis. See, more than the risk factor, the severity of the thrombosis also determines the duration. Sometimes if the patient gets a life-threatening thrombosis, no matter whether he has got a prothrombotic tendency or not, you have to go for a lifelong anticoagulation.
Sure. Next slide.
So you decide based on various factors, the risk factors, the age, and the site of thrombosis, and the intensity of thrombosis to decide whether it's a short, which means 3 to 6 months, prolonged, which may be 2 years, and lifelong. So these are the factors which will help you to decide. And in case of arterial thrombosis, you would like to add aspirin.
Sure. So you say then venous thrombosis, there is no role for aspirin. Am I right? Sure. Next one. So I think currently, shall I say that we agree upon starting some injectable anticoagulants as of now, and probably to keep him nil per oral till his abdominal symptoms settle down, and some antimicrobials to take care of J infection. Are we in agreement? Yes. Next. So I think as a madam has said already, we did a protocol-based OJD which showed large varices into 3 columns with red veil sign, and type 1 esophagogastric varices are seen. Now comes the dilemma. Do we do anything for the varices? Is there a need for discontinuing anticoagulant treatment? So the question now comes, is there a need for an intervention? And if there is a need for an endoscopic intervention, do we do banding and glue before anticoagulants, or initiate anticoagulants and intervene later if he bleeds? Yeah, ma'am. Next.
Yeah, if the varices are, it has to be known to us prior to introducing even anticoagulants. And if the patient has high-grade varices, I think target should be to tackle this before introducing anticoagulants, because
Sure.
we do know that we have problems after introduction of anticoagulants and then proceeding to tackle the varices.
Certainly. Next. Okay, we will skip these slides, ma'am. Next. Next. Yeah, at this point, I think, ma'am, you can highlight this.
Yeah, that's what I mentioned, that upper GI endoscopy is necessary prior to initiating oral anticoagulants. One is because, we also need to know whether there are associated ulcers in these patients. And once you introduce these, you can get a high incidence of bleed. And but also interesting to note is that an endoscopy is quite safe with an INR between 2 and 3. So if this patient does have an INR of 2 to 3, we can still manage the varices. It will almost be similar to a chronic liver disease with an INR of 2 to 3.
Sure.
And length of warfarin, doctors already described. So either it's going to be short duration if it is non-primary, and maybe lifetime if it is
Sure.
primary.
Next slide.
Yeah, that's what. So this I think will.
Yeah.
So if
Here there is one. Is there any recent information that vitamin K is not necessary in correcting deranged PT? Is there any information currently available?
Well, the thing is, you have written more than 3. If it is, I wouldn't worry if it goes to 4 or 5, but if it's very high, vitamin K, the only point to be noted is it should be given 1 to 2 milligram. Because the problem is comes as a 10 milligram.
Yeah.
Everybody has the urge to give 10 milligram immediately. And if you give 10 milligram, it will be very difficult to re-warfarize again. That is the problem.
Okay.
No, vitamin K, the thing is, warfarin acts by depleting the vitamin K in the liver. And vitamin K is stored in the liver for a longer time. And if you give 10 milligram, it takes a larger dose of warfarin to deplete the vitamin K. So what the patient was on 5 milligram of the problem if you give a larger dose of vitamin K. So you can restrict to 2 milligram, and 2 milligram will promptly restore the INR to safe levels within 24 hours.
Okay.
And you may have to give FOP only if you encounter an active bleeding. Yeah. Actually, that's why it's vitamin K is necessary for the formation of the coagulation factors. So this acetone acts by depleting the vitamin K. Yeah,
Like,
12 to
take
24.
mic and ask
12 to
questions.
24.
Take mic and ask questions. And yeah, we'll go to the next slide. So I did not do any endoscopic intervention because we have
I
already.
think that vitamin K bit, I think you have to stress, because I think many of us would really not know about
Yeah,
that.
but only
Getting
thing, you will
vitamin
have to get to mic and talk. Otherwise, people will not
No, that's
hear.
what. So,
Yeah.
So we'd really like to know that suppose the person comes with a bleed and his INR is 3, when should we give the vitamin K and when